Hello, thank you so much for joining. We're going to take a few minutes to let people enter the webinar, and then we will get started. And people are coming in. Hello and welcome to TMA's Ask the Doc webinar series. My name is Rachel Bromley. I am TMA Senior Manager of Patient Education, Support, and Advocacy. Today we have the honor of speaking with Dr. Elie Naddaf. Dr. Naddaf is a neurologist specialized in neuromuscular medicine and muscle pathology. His research interests include inclusion body myositis and less common immune-mediated myopathies, such as sporadic late-onset Nemaline myopathy and graft versus host disease myositis. His translational research, funded by the NIH and the American Neuromuscular Foundation, is focused on the role of mitochondria in inclusion body myositis. Thank you so much for joining us. We're happy to have you.
Hi, Rachel. Thank you for having me. It's my pleasure and my honor to be here today.
Well, I forgot to mention, he is also a new member this year on TMA's Medical Advisory Board, and we are just so excited to have him. And this is his first activity with the MAB. So thank you for that. We are excited to spotlight your research and also give the audience a chance to ask their questions. If you have a question for Dr. Naddaf, you can put it in the Q&A at the bottom of your screen. And before we start the Q&A, we will go ahead and let Dr. Naddaf tell us a little bit about his work.
Yeah, thanks, Rachel. Yeah, I'm a neurologist at Mayo Clinic. I mostly practice neuromuscular medicine and muscle pathology. Currently, research-wise, my main research is on inclusion body myositis. I'm on an NIH grant to study the role of mitochondria in this disease. And I've always been fascinated by all the common features between inclusion body myositis and other diseases of aging. And the mitochondria is a main driver in all these diseases. So I was excited and looking forward to starting this project. On a clinical side, I've also been involved in clinical research on IBM, mostly population-based studies where we looked at survival, at what conditions are more common in IBM than the general population, at the atypical forms of IBM, and also at how the clinical features in IBM correlate with the muscle biopsy feature, trying to just understand a little bit more the complicated disease mechanisms in IBM. And that's it in summary. I believe in order to find better and more treatment options, we have to better understand the disease mechanisms. That's like a must to move the field forward.
All right, well, thank you so much. Go ahead and put your questions in the Q&A and we will get started. For patients with IBM, can finger strength flexion be improved and how?
Yeah, thank you, Walter, for asking this question. So far in inclusion body myositis, so far we do not have a treatment. So there is no pharmacologic treatment that would help improve the weakness in general, including the finger flexion weakness. However, there is growing evidence for the important role of exercise in IBM. And how much it would improve the finger flexion in particular, it's tough to say, but the exercise is very beneficial in general. And occupational therapists are also very helpful to address the needs of patients as far as their hand function. And in some patients with more advanced weakness, they are also very helpful in providing ideas for tools that can be used to overcome that weakness.
All right. Can a keto diet help repair mitochondria and help inclusion body myositis?
We're starting with the very difficult questions. Thanks.
Oh, and then also, yes, we don't say the names. Just so you know, I forgot to prep you on that.
Oh,
so
okay. Sorry for that.
Yeah. That's fine.
Because Yeah, I mean, there's a strong link between ketogenic diet and between the mitochondrial health in general. And there have been studies there have been studies of ketogenic diet in general and the relationship with mitochondria. I don't think there is evidence yet to support its use in IBM. And I am not recommending any particular diet. The only thing I would say about ketogenic diet in particular, it is one of the more challenging diets. So it's a little bit difficult to stay ketogenic for a long period of time because really there are very limited types of food and that you should or you should not eat. So that's the major challenge with ketogenic diet. It's been used successfully in kids with severe epilepsy, and these kids usually have a feeding tube. So it's much easier to control what they eat and control the amount of fat that goes in, the amount of carbs that shouldn't go in, and to keep them ketotic. We actually met with one ketogenic diet expert to discuss about the possibility of it in IBM. I mean, it's an idea out there. It just, from practical standpoint, it's a difficult diet to follow.
Mm-hmm. All right. This person heard that there was work being done on a word I can't pronounce. Do you see it in the chat?
Yes, yes.
Okay, thank you, for its effect on mitochondrial function. Can you please comment?
Yeah, sure. Pioglitazone, and interestingly, all the diabetes medications have some effect on the mitochondria. And the one that even has even more interesting effect on the mitochondrial health in general, it's metformin. And there are many, many, many other drugs targeting the mitochondria. Actually, they've been blooming in a new what's called mitochondria-targeted therapeutics for Alzheimer's disease, for Parkinson's disease, most of them at very early stages of development. So it would be interesting to see how they do in a clinical trial in IBM. However, sirolimus was currently in a phase 3 multi-site international trial in IBM. One of the main mechanisms of action of sirolimus is also working on the mitochondria, improving the mitochondrial health and improving the autophagy. We will wait and see how that will go. A challenge with sirolimus is to get enough concentration to the tissue, like in animal models. It's very difficult to penetrate, for example, the CSF brain barrier. However, how it will do in muscle, it's yet to be determined.
Okay. This person has benefited from IVIG despite most studies suggesting that IVIG does not help IBM patients. What are your thoughts about the use of IVIG?
I think among all the immunosuppressants that have been tried in IVIG and that have failed, that have been tried in IBM and have failed, the one that there's still so many unanswered questions about is IVIG. So if you look at IVIG, I mean, there were clinical trials, one of them randomized double-blinded trial, and another trial that in general on a group level, there was no response to IVIG. But there are some patients that improved. And most importantly, there are some cases of mostly the swallowing improving with IVIG. We don't recommend using IVIG in general, because in general, in the bigger scheme of the disease, so far we have no evidence that it changes the disease course. I think the cases where I would consider it, but I would have a detailed discussion with the patient, with the pros and cons, patient where the dysphagia is really problematic, and even if it would give us a temporary relief without changing the whole disease course, maybe we could consider it. Now, having said that, there are patients that respond to some medications in general, but based on the evidence we have, when we look at the patients on a group level, on a clinical trial, it seems these medications are failing in changing the progression rate of the disease or the outcomes of disease. That's why so far, most experts do not offer any immunosuppression or any treatment for patients with IBM.
Recent studies show that exercise is beneficial for IBM patients, but nothing conclusive about actually gaining muscle back. Can you address this, please?
Yes. So I think the whole literature about exercise went from exercise is harmful and patients with any muscle diseases were told not to exercise decades ago, more expert opinion. And then it switched to exercise. Maybe it's not harmful. Maybe we should consider it. And now we're starting to see more actually beneficial effect of exercise. You're right. It may not help you rebuild the muscle in that strength, or at least we don't have evidence to say that. You go exercise, your finger flexion will improve. I wouldn't say that. But overall, it makes, how to put it there, like it gives you the best use of what you have. And definitely, if you exercise, you would be stronger in general. Whether it would target these weak muscles, I'm not sure. And it's very difficult to prove it in a study, especially over a short period of time. I think potentially from mechanistic perspective, I think the exercise could help improve to some extent. But I cannot prove that to you in a clinical trial.
What do you think about supplements for mitochondrial function?
Supplements for mitochondrial function, that's a very good question. So there are inherited mitochondrial myopathies, where they're called the primary mitochondrial myopathies, where we know that the main defect is in the mitochondria. So the mitochondria is the primary source of their disease. And there's what's called the mitochondrial cocktail, bunch of mitochondrial supplement there. Even in those diseases where we know the primary genetic problem is in mitochondrial gene, the supplement don't seem to overall make any difference. So let alone in IBM where they're not even studied. So overall, I think there is no evidence as of today that just the general mitochondrial supplement that are available out there, like coenzyme Q10 or others, alanine amino acid, and there are many others that are strongly linked to the mitochondria that would make any significant difference.
Can you tell us about your clinical practice? How many patients do you see? How often do you see them? And what is the experience at Mayo like?
Yeah, sure. My clinical practice, so all my clinics are mostly subspecialty clinics. So I see patients with mostly muscle diseases, but also with nerve and other neuromuscular diseases. We have a large number of IBM patients at Mayo as a group, not necessarily just myself. I'm one of the younger ones here. But
I wasn't going to say anything, but yes, you do come off as young.
Yeah, so I say we have large numbers. For example, in our atypical presentation of inclusion body myositis, atypical presentations happen in about 14% of patients, and over 5 years, our study has 50 patients. So I think we see between 90 and 100 IBM patients per year between us and rheumatology. How often do I see them? What makes IBM distinctive from other inflammatory muscle diseases that the progression is really slow. So I make sure I see them every year, once a year. I make sure I check on their swallowing once a year, answer all their questions, tell them what's new in the literature, go over clinical trials with them. So as a routine follow-up, I see them once a year. And now if something comes up prior to that, I can always see them sooner rather than later. And they can always message me if anything comes up in between.
Great. All right. Have you seen more military veterans with IBM versus the general population?
This is a very interesting question that I was recently also asked about by someone else. That's why I went back and looked in the literature in general to find some guidance there, and I didn't. Then I went back to our epidemiologic project to see if I can, because that's something not difficult to do. Unfortunately, the medical records do not contain the veteran status of a patient. So I thought we'll go back, we calculated the incidence prevalence, we'll just divide them by veterans versus not, but that information is not there. And so I cannot answer that question because on a case-by-case cases, it's difficult to say if it's more in veterans or not. We don't have a VA hospital in Rochester. I had the honor of working at a VA hospital during my training at the University of Wisconsin in medicine. And that was my favorite. The VA clinic and working with the veterans was my favorite, but we don't have data yet on that. It's feasible to do a similar project. We'll probably have to pull several centers together. I see it could be done, but it hasn't been done yet.
I know that earlier you talked about supplements and how they help with mitochondria, but did you specifically cover CQ10?
Yeah, so Coenzyme Q10 is also one of the main mitochondrial supplements. Even in primary mitochondrial diseases, unless you have CoQ10 deficiency, doesn't make a big difference. I'm personally not a big fan of supplements in general, because I think unless you have deficiency of that specific vitamin or supplement, I'm not sure taking more of something like more of alanine amino acid or more of vitamin B12 or more of a multivitamin would do anything. It basically gets washed out in the urine. And I leave the decision for my patient as long as the supplement is not harmful. CoQ10 is not harmful at all. B12 is not harmful. And I tell them also they could spend this money on something else, like maybe a nicer piece of steak will give them maybe more vitamins than that bottle, but I'm not opposed to it. But I don't think there is much evidence to use any supplement unless you have deficiency. So if you have CoQ10 deficiency, which is a very specific gene, that's a no-brainer. Riboflavin deficiency, no-brainer, go get these things. B12 deficiency, but other than that, unless you follow a very strict diet where you don't eat everything, there's not much evidence to use them.
This person has been told by their neurologist that he saw mitochondrial issues in their muscle biopsy. How does that present itself?
Oh, yeah. Am I able to share a figure or something to show?
Of course, yeah. You can share your
that.
screen.
Let me show you how it will present. Let me just first get a photo. Maybe I like one from, see, Frontiers in Neurology review article. Here's a photo we just published. So let me show you how it presents itself. Rachel, can you see the figure?
Yes.
Very good. So this figure here shows you how the diagnosis of IBM is made on muscle biopsy. And basically, IBM here in panel A, these are your muscle fibers, and the dark blue round circle stuff are your inflammatory cells. So you see the muscle has inflammation, they're surrounding the muscle fiber, and as if they're chewing from the muscle fiber, like here, almost splitting it in half, here completely split in half. That's what's called the endomysial inflammation. And that's when you don't see the rest, the B or C or D, people mistake it and call it polymyositis. Now, what's special in IBM is the other features. So what you see here in B are more like actually like garbage bag. This is the disposal system of the cell to get rid of its garbage. But because that system is not working well and it's aged in IBM, it can't keep up and those accumulate. These are called the vacuoles, autophagic vacuoles. And the same thing, because the whole environment is not working well, in some fibers, some proteins start to deposit. And that's when you hear you had congophilic inclusions or protein aggregates. And these are the protein, if you take, let's say, do a proteomic study, see what's in them, you find them, all these protein are common with all these diseases we talked about. especially TDP-43, beta amyloid, prion-like protein that you see in Parkinson, in ALS, and so on and so forth. Now, the most interesting one is in D. These are the mitochondrial changes. So normally, the muscle fiber have enough mitochondria, which you see here in brown. That's the cytochrome C oxidase. It's a color for the mitochondria. Then in IBM, you start to see those fibers here that are white that lack color. That's when you see in your biopsy report or you had the CCO, cytochrome C oxidase, negative fibers. So that's the mitochondrial dysfunction that is seen in more than 90% of patients in IBM as early as day one. We had a few cases that we published in the atypical form that were completely asymptomatic, but even from day one, you see mitochondrial changes. So that would be the mitochondrial changes on muscle biopsy.
Okay, what can you say about the technology being explored by AbCuro? The community has great hopes for ABC 008.
I wish I left my figure up. Let me put it back up.
Yeah. We're flexible.
So the reason why, or one hypothesis, one thought, why all the previous immunosuppressants didn't work in IBM. Because these cells here at the front runners, the cells that are actually eating up the muscle, they are a very specific population of T cells that are called the highly differentiated T cells. It means these are T cells that have been there for a while. They became highly differentiated, so they stopped dividing, they stopped proliferating. And one thought, one theory is all the other drugs do not affect these T cells. So that was the reason why people who think inflammation is primary there or there's no doubt it's an inflammatory disease. It's adding to the disease burden, but because all these drugs fail to target these T cells. And how do we know T cells? They have a marker on their surface called the KLRG1 protein. So AbCuro, the ABC008, that new study, it's a monoclonal protein. So it's a manufactured antibody that will go after that KLRG1 protein. So it's targeting these highly differentiated T cells to eliminate them and see what happens.
Wonderful. Thank you. Can you speak in layman's terms about what is known about the mechanism that eventuates an IBM? What progress is being made to understand this disease etiology?
Okay, so so far, we mostly describe different mechanisms that are involved. We don't understand how they work together. So what we know so far, our immune system, the inflammatory cells are there chewing from the muscle fibers. What drives them? We don't know. Are they the primary problem? We don't know. Two, we know that in IBM, that garbage disposal system called the autophagy is not working like it should. It's not clearing all these protein, the proteins that shouldn't be in the cell. The dysfunctional protein is not clearing it there. That's that. And we know also just a little, so we know a lot about that inflammation. We know very little about the non-inflammatory stuff. And we know also in IBM, for example, the mitochondrial health, the oxidative capacity, we know very little is also declined. So as you see all these like fragmented picture, we don't know what's driving them, what's the main source, what's the main cause. And there are, we could talk there for hours on different hypotheses and each of them, what it fails to explain. But that's in a nutshell what we know so far.
Do you support a trial of steroids for recently diagnosed patients?
I do not, for different reasons. First of all, in clinical trials, there's no question about that steroid failed. The steroids can have side effects. There is no evidence for any immunosuppressant. We always think about whether a treatment is beneficial or not, but we forget that a treatment might be harmful. I don't think that's established with certainty, but there are some clues out there in the literature that actually the treatment with steroids could be harmful. there is a paper by the French group that showed the group that was treated with steroids needed a wheelchair earlier. Now, these are all chart review studies. It's difficult to control for confounders, but that's what they saw. And then in the population-based study that we published last year, it's called Survival and Associated Comorbidities in Inclusion Body Myositis. When we looked at the survival of patients, if we divide them by the group that were treated with corticosteroid versus not, the group that treated with corticosteroid, at least in that study, seemed to have lower survival. Now, I'm not saying corticosteroid caused the lower survival. I'm saying it's a hint that it's not that it doesn't help, it could also be harmful. So I do not use corticosteroids or immunosuppressants, at least in my patients.
You think that the way studies are designed in terms of what constitutes improvement may rule out some treatments, even though quality of life is improved?
Unfortunately, yes, I agree with that question. So clinical trial, for its treatment to succeed in a clinical trial, not only the drug has to work, but also we would have to have the right tool to measure that improvement. And the trial has to be long enough to capture that improvement. So yes, there have been studies that were very short, like one of the IVIG study was only 12 weeks, for example. And the tools that are used, they weren't designed for IBM. They were all borrowed from other diseases. And that's one thing we're looking at with the IMAX, to look at all these outcome measures that have been used in IBM, try to have a set core of measures to recommend. But I think also we need new outcome measures as well. And the patient-reported outcome measure, they have great advantages. I would just list a couple. One, from scientific standpoint, you can just with a questionnaire address so many aspects of the disease. You can address swallowing, hand function, leg function, rather than just a test where you're measuring their distance and how much they walk in a 6 minutes. So it can have a better content, that outcome measure, and it would be much more valid. And obviously, I think that now there's a project not published yet or working on. Sometime the concern with the quality of life measure is that there's a placebo effect. And that's seen a lot, for example, in myasthenia gravis trial, 20 to 30% of patients had placebo effect to the drug, which would but I personally don't think that happens in IBM trials. So I'm not concerned about that in IBM, because that would be one reason why the quality of life measure may not be supported or used. But obviously that quality of life measure has to be tailored to IBM and not just a general quality of life measure.
Comfortable are you that we have good, reliable endpoints for IBM clinical trials? Which one do you think is most likely to succeed with such a slowly moving disease?
That's a good follow-up to the discussion we just had. If I have to pick one, I would pick two, and I will tell you why. From what we have, obviously, everything has its disadvantages. We don't have a great endpoint measure yet, I think. From what we have, I think two stand out so far. One is the IBM FRS, the IBM Functional Rating Scale, where you ask the patient a series of questions and still filled by the physician. So that's one. Why? Because it captures various aspects of the disease. You talk about your swallowing, your hand function, your leg function. And I'll tell you what the issue with it, but also measuring the strength, I think overall it's the one that correlates the closest to the disease. The problem is everyone does it so differently. The normal values are not standardized. The scale used in each trial is different, but I feel if everyone comes together, standardize the dynamometry, how to measure strength, and have like a very defined protocol that everyone follows, that would be also promising.
Thank you. There was a study done in Boston University regarding exposure to environmental contaminants and a significant increase in TDP-43. Are you familiar with any link to these contaminants in the development of IBM?
I'm not familiar with this particular study in general. TDP-43 aggregation in IBM, it's actually a hallmark of the disease. Dr. Lloyd and his colleagues did very nice study on that protein lately in particular. I am not aware of what the exact nature of these contaminants, so I cannot comment on that. In general, there hasn't been a clear evidence in the literature to link IBM with any particular contaminant, number one. Number two, we don't have clear studies, but overall, I would say the prevalence of IBM is relatively similar. It's across all the world, all the countries, all races, all ethnicities, different types of diets, different type of exposure. It's not that disease that's really confined to certain areas, certain exposures. That tells me, or gives us an idea that probably what's driving the disease is beyond an exposure to something environmental or a contaminant or something toxic or something like that.
Are there any new interesting trials going on in the world?
Unfortunately, there are only two. I think we're running out of medication to test. That's why we need to come up with a new disease mechanism and new pathways and just open up the door for new medications to be tried. The only two that are ongoing at this time that we're aware of, but I'm not sure there is other treatment trial, pharmacological treatment trial. One is the one we just talked about, the ABC008 that targets this KLRG1 cell. This is an international study with so many sites in the US, outside the US, we're a site. So wherever you live, you can look up what's the closest site to you. It's at early stages. Some sites have already been activated. They're starting with phase 2, the first phase, and then we're moving on to phase B, which is more phase 3. Our site is very close to be activated. So these would be the two main ongoing, so that's one. And the second one is the sirolimus drug. In the USA, there are only two sites, Kansas University Medical Center and Johns Hopkins. These would be the only two sites in the US. There are additional sites in Europe, and sirolimus work is mostly led by the French group.
This person was diagnosed with IBM at Mayo, Rochester 10 years ago and has been followed by my local neurologist. Is it beneficial for her to return to Mayo to be re-seen by a specialist?
You'd be most welcome to return. Do you need to return? I think if your neurologist is familiar with IBM, you'd probably be okay. Familiar with the new development of the disease, familiar with the complication of IBM. Basically, simply to simplify it, your local neurologist has to follow up on your swallowing, on your breathing, and make sure these are followed and monitored, not just if we don't have treatment, we just don't follow up. These are important to monitor at least on a yearly basis. Now, for what's new in the field, you can rely on them, but you don't have to, like great resources like the Myositis Association and other also association can be your source for information rather than your neurologist if they're not up to date with what's new.
Should a neurologist always be a part of a myositis care team, or does it differ based on what type of myositis a patient has or what symptoms they are exhibiting?
A neurologist does not need to be a part of every patient with myositis. I think a neurologist should at least be involved if there are questions about the diagnosis with any type of myositis. If someone is being treated for any type of myositis and not responding, then you need to see a neurologist, because we need to also consider other diagnoses that could have been mistaken for myositis. Some forms of muscular dystrophies, like one of them, facioscapulohumeral dystrophy, can actually have inflammation on biopsy. and now there are clinical trials for FSHD. So for a diagnosis, I would say if there are doubts of the diagnosis, you're not getting anywhere with the treatment, it's a good time to be seen by a neurologist. Now, depending on the type of myositis, neurologists tend to take more ownership of the type of myositis that mainly affect the muscle. Inclusion body myositis, for example, I personally see patients with IBM. I manage also patients with necrotizing autoimmune myopathy and the other rarer forms we talked about. In myositis, patient that's just a part of a multi-organ disease like dermatomyositis or antisynthetase syndrome, where they could have lung involvement, skin involvement, you'd better be followed by an internal medicine person, mainly a rheumatologist. So that's just a subtle distinction between the types of myositis.
Do you have any ideas for repurposing an already approved drug that might offer help with the mitochondria?
Yes, repurposing drugs is actually a great way to save time in phase 1 trials, save time in figuring out the dose. For example, sirolimus is a repurposed drug. KLRG1 antibody is a novel drug that wasn't there. And there are other drugs that would target the mitochondria, for example, like metformin and others that could be potentially tried.
What percentage of IBMers end up wheelchair bound?
End up wheelchair bound. Unfortunately, IBM really likes the quadricep muscles. And I would say a significant proportion of patients, depending for how long you have the disease, what age you started. So let's say if someone started at the age of 50 and they live long enough, it's likely that at some stage they would need a wheelchair. If you like numbers, just be mindful that it's very variable from one patient to another. The average time to use any assistance walking, not necessarily a wheelchair, is about 8 years. And majority of patients, 15 to 20 years from onset would require a gait assistance or even a wheelchair. So wheelchair is common in IBM if you had the disease for long enough.
Can you talk about IBM survival and comorbidities?
Sure, I'll give you a brief summary of that paper. So originally, IBM was thought to not affect survival. It means if you have IBM, you live the same as if you didn't have it. But at the same time, the leading cause of death in IBM patient was aspiration pneumonia, which is not, or swallowing complication in other terms, which is not the leading cause of death in the general population. So it didn't make sense that it's not affected. But also the original study more compared the group of IBM to the general population. So statistically, it's very difficult to find the difference. Lately, we and other groups, not just us, have shown that actually IBM does affect survival. So in our study where we compared each IBM patient, we had 6 age and matched population control. The survival in IBM was a little bit modestly shorter. On average, IBM patient lived, not dramatic difference, I would say 3 to 5 years less. So the average age of death in the general population was about 80, 81, if I recall the number exactly, while the average death in IBM was like 77, 78. So that gives you an idea. Briefly about the associated comorbidities, given all the things I've mentioned about common pathology, we were interested to see if there is any increased risk of Alzheimer's disease, Parkinson's disease, dementia in general in IBM, and we didn't find that. So there's no evidence that IBM patients have increased risk of any of these neurodegenerative disease. They have no increased risk of solid tumor or cancer, because other form of myositis like dermato with some antibodies may have increased risk, not IBM. 3 comorbidities were more common in IBM compared to the population. 1, IBM patients were more likely to have peripheral neuropathy, which would manifest with numbness, tingling in the feet. 2, IBM patients were more likely to have Sjogren syndrome, which is a connective tissue disease that manifests with dry eyes and dry mouth. And 3, patients with IBM were more likely to have a super rare form of leukemia called T large granular lymphocytic leukemia. Now, this leukemia is as interesting as IBM because it has its peculiar features, and most patients that have it don't even need a treatment. So these would be the 3 conditions that would be more common in IBM.
Do you think the advancements in AI, artificial intelligence, may lead to new health discoveries? And are there any discussions about AI use and research for IBM treatments?
That's a great question. There is a discussion about the use of AI in neuromuscular diseases in general, including IBM. I'll give you an idea. For example, there is an interest in seeing if AI can highlight areas of interest on muscle biopsies, can, for example, direct what genes are likely based on the muscle biopsy, for example. Maybe AI could help in IBM, maybe not needing a muscle biopsy, let's say looking at certain blood biomarkers. The challenge with AI in neuromuscular diseases and in IBM, first, we're at early stages of AI development, so there probably will be more and more coming in the future. But one of the main challenges to develop an AI algorithm, you need a large data set to train your model. Then you need another independent large data set to validate your model. So that gives you an idea why it's easier to develop AI programs for high blood pressure or diabetes, those type of diseases where we have millions and millions of patients with them. It's not impossible. Of course, it's very feasible also in rarer diseases, just more challenging.
Some people have been diagnosed with large granular lymphocytic leukemia along with sporadic IBM. Is there any speculation why some people are affected with this and others aren't? And are there any effects on or correlation with the mitochondria?
Very good question. And I'm glad you asked that because I want to clarify something. So when your doctor tests you for that, they are testing for these cells that are present in the blood. So the better term would be a good proportion of IBM, like in the study by Dr. Greenberg, about 25 to 30% have that clone in their blood. So we'd say you'd have a large granular lymphocytic clone, not leukemia. Leukemia is much rarer. And to have leukemia, you have to have end organ damage. That means you have to have, let's say, anemia, neutropenia, other cell lineage affected, high LDH, and most of patients with IBM that have that clone do not have the leukemia, and that's why majority of patients with the LGLL clone will not need the treatment. So that's one. We don't know why some are affected and others are not. We don't know if the leukemia or because these cells are continuously stimulated in the muscles, then a group of them start multiplying on their own and they form that clone. We see that type of leukemia or clone in other chronic diseases like Sjogren, I think reported in rheumatoid arthritis too. I'm not aware of a correlation with the mitochondria though. Yeah, I'm not aware of any correlation there.
Do you have any concerns about side effects of Abcuro 008? Who should consider participating in phase 3 trials of it, and what are pros and cons?
That's a good question. And that's why the trials are done in a certain way where you have first phase 1. And the phase 1 has not been published yet. There was some announcement of some safety data that overall it was safe. There were no serious adverse events that were seen, but also, of course, we wait to see the full results of that phase 1 trial. And that's why in the current phase, it's a phase 2-3 trial. So there will be a number of patients going first. That will be the phase A of, to not confuse you with the number. The study is phase 2-3. The first part of it will be more phase 2, that they will have, I think, up to 30 patients. And they will be really strict safety requirement. And at the end of enrollment of these 30 patients, there will be an independent board called the SMB board that will look at the data, make sure there are no red flags, then give the green light to move on with the rest of the patient, additional 200 patients that will be in phase 3. Pros and cons, I think to find a new treatment, we have to have a clinical trial. So it's a collaboration between patients, physicians, a sponsoring pharmaceutical company to move forward with it. I don't think there's a major cons. What I tell my patient, where the trial location is very important, because clinical trials also have to be at a convenient location. You will be going very often for follow-up. Like in the Atypical trial, they require a certain amount of follow-up. So you can't really travel to the other side of the country that often. So I would say the main con would be if you live somewhere that's really a hassle to travel or you have to fly for your visits, then that's something to consider. Otherwise, we don't know if the treatment works or not, so we don't know. So I wouldn't participate in a trial because there's a treatment that works just to get it before everyone. Every treatment in a trial, that means we don't know if it works. So there's a 50-50 chance that it may or may not work.
Do you have any thoughts on why Olmsted County in Minnesota has reported the highest prevalence of IBM per population? Is it because the patients moved there to be closer to Mayo, or were they already living in Minnesota?
That's a very good question. And I think there are several factors there, not one. When you look at those different prevalences, they use different methods. So there's also the method that you use, how sensitive it is for the diagnosis of IBM. For example, one of the studies with the lowest prevalences only used muscle biopsy databases in one country. And who knows how many patients are getting a muscle biopsy in the country or being referred. Our study here from the Olmsted County had the higher prevalence. We used the ANMC criteria, which are more sensitive than previous criteria. 2, living also near a big center and having a good health system here, patient can easily be seen directly by a specialist, have easy access to muscle biopsies. So does not really reflect the prevalence in other areas of the country. That would be another reason too. I always wondered about patient moving to Mayo, but when doing chart reviews in IBM, I mean, these patients are local and they were diagnosed after they moved here. So I don't think that's a strong factor, at least in IBM.
Can you describe what you meant when you said atypical presentations of IBM?
Yeah, of course. So we have a challenge in IBM that there is often a delay in diagnosis. First, because it's the weakness is has a lingering course rather than a dramatic course, which is good. So it's more a slowly progressive disease. But on average, the delay in diagnosis on average is about 6 to 8 years. So someone would be living with the disease for many years before being diagnosed. Now imagine we have an effective treatment, or imagine we have a treatment where we need to capture the patient as soon as possible to treat them and see some benefit. So it would be very, very important to really nail down the diagnosis. Now, all physicians are familiar with if a patient presents at a certain age with hand grip weakness or quadriceps thigh weakness, they think of IBM right away. However, there are so many other presentations of the disease other than these two. And these are called the atypical presentation, if you wish, the less common presentation. So in our study, the most common presentation after hand grip and leg weakness was actually dysphagia. So there are some patients that had just difficulty swallowing for years before they were diagnosed. And that's very important, as aspiration pneumonia is the leading cause of death in IBM. So half of the patient with the atypical presentation had dysphagia. What are the other atypical presentation or less common presentation? Now with the availability of antibody, more access to biopsy, we're capturing patients in a pre-symptomatic stage, like before they have weakness. They just have a bit of high CK or some muscle aches, that's two. There are patients that present with foot drop, that's also a presentation. And the less common presentation, also patients that present with axial weakness, head drop, they can't lift their head up, or their posture, they become hunched over. And one of the most interesting presentation where we had two in our series is actually complete facial weakness on both sides. So it's called facial diplegia. So all these muscles can be involved in IBM, but we need to highlight that they can be the first symptom on IBM. So if a neurologist there seeing someone with just, they can't swallow, they don't just send them for a swallow eval and we're done. We need to look if they have IBM, or if someone has complete diplegia, or a foot drop that looks as if they just pinched a nerve by their knee, but usually more slowly progressive. So these would be the atypical or the less common presentations of IBM.
Okay, we have just a few minutes left, and there is someone in the audience, Jim C, with his hand raised. Jim C, I'm going to open up your mic. I'm going to allow you to talk. You are currently muted. Jim C, if you're still there, you can ask your question, unless you accidentally put your hand up. Yep, I think it was an accident, so. All right. Well, thank you so much. Do you have any final words for patients? Anything that would take us out on a positive note?
Yes. In the last few years, we've been having more development in the treatment landscape in neuromuscular diseases like it has never been seen before. And that's all the result of everyone now appreciating that in order to succeed, we all need to collaborate. All the boards, all the association will have to have the patient representative, the physician, the pharmaceutical companies sponsoring these trials. And there has been a really growing interest in finding cures to rare diseases, although you could argue IBM is the most common one, most common muscle disease, but it still falls under the rare disease. So I think it's an exciting time. Several groups working on so many different aspects of the disease, others working on developing better outcome measures, better clinical trial designs, platform clinical trials, and so on and so forth. So I think it's an exciting time for me as a early career physician and for everyone in the field to see how things will evolve, and hopefully we'll have some treatment options for so many diseases, including IBM soon.
Right. Well, thank you so much for participating and lending your knowledge and expertise to the myositis community. We really appreciate you, and we're happy to have you on the MAB. He will be at the annual patient conference if you'd like to take a look. We still haven't gotten together and talked about exactly what your topics are going to be, but I'm sure it will be phenomenal. We also have our virtual summit this Saturday. So if you would like to register for that, you can go online, and everyone who registers will have access to all content for 30 days. So no, you don't have to sit on your couch for 8 hours. You can take your time watching everything that we're offering. So thanks again to Dr. Naddaf, and for TMA, I'm Rachel Bromley. Good night.
Thank you. Good night.